That being said, Dr. Dydyk, welcome to the podcast.
Thank you, Scott. Thanks for having me today. I appreciate it.
Of course. So tell me about your journey. Where did you go to school? What led you to pain management? And how did you get there?
So it's, I think most doctors would say it's an interesting story, right? So I think you get people who've got family members who are in medicine, who are doctors, and they get to see that pathway. So first doctor in my family, and kind of going through that process has kind of been all new to me. I make a joke all the time where my number one exposure to medicine growing up was watching TV, right? So you base things off of, watching like ER and Scrubs and Grey's Anatomy, and then you kind of get into it and you're saying, oh my God, that's not what it's like at all, right? So, but I grew up here in like Phoenix, Arizona, kind of born and raised. I actually did move out of state for quite a long time. I was an undergrad here at ASU. Was a biology major, actually started in engineering to kind of follow my dad, but definitely realized that wasn't for me that quickly. Was a bio major, and then I worked simultaneously full-time at a gym while I was there too. So was kind of student full-time and then also working full-time. And then about right before I graduated from college, I walked up to the health office and said, I was thinking about maybe I should be a doctor. And then he looked at me and said, maybe you should have came here like 3 years ago because now there's not a ton for us to help you with at this point. So I had to go take some more coursework, and go back, go take an MCAT, started volunteering a lot, get some more letters of recommendation, go through that process. So 2 years after I graduated from college, I then got a master's degree in biomedical sciences from Midwestern. It's kind of like a pre-med master's program where you do a crazy amount of credits, like almost like 90 credits in like 1 year. Okay, and just kind of all kind of slammed into there. And when you do that process, it's kind of like you're doing your like first year of medical school all in one spot. And I liked Midwestern a lot here in Phoenix, actually in Glendale, Arizona, and ended up going to medical school there. So I decided to become a DO, which was kind of a process of deciding if you wanted to be a DO or an MD. The biggest difference between, I really like the idea of getting my hands on patients. We do manipulations, and their general kind of framework of kind of taking this kind of broad and holistic approach is something that I just kind of took with me for kind of the rest of my career going on after that. When I got to medical school, I would love to say that I knew I was going to be a pain doctor, but I didn't. At first, I was like, hey, should I be a psychiatrist? I was debating about getting a PhD in clinical psychology, going down that road, versus if I wanted to be a surgeon. So I spent a better part of 2 years thinking I was going to be a urologist. So my surgery director, or my surgery person for medical school, had a lot of influence on me. I thought that was great. I was in surgery club, and I was doing things where you go to, I think we went to even nationally, we went to Iowa to go to a surgery conference, and that was all great. And then some things kind of changed in my life pretty quickly. I had a daughter and got married, and then I started going on rotations. And so rotations, you spend time in various kind of facilities, and I had this whole schedule kind of built that was kind of pre-surgery. And then what ended up happening was I realized I was never home. And then, like I said, you watch a lot of TV and you have this idea of how things were. And, even some of the things that were kind of funny was, you start your day and like, no, you're going to go around on patients at 5 a.m. We start our day at 7, but you're going to see all the patients first before you even get there. And then you're going to be there till 6 o'clock at night. And for better or worse, when you become a new parent, you realize fairly quickly that not everyone else just became a new parent. So they weren't kind of taking on your responsibilities at home and life. And so that was kind of a culture shock for me. And I ended up really liking some of my family medicine rotations. So family medicine, kind of broad, kind of holistic kind of approach too. And Midwestern has a lot of people who go down that road as well. And I did really well in those rotations. I liked it a lot. I did a sports medicine rotation as an elective, and that was good. So I switched up from a lot of the surgery stuff to family medicine, and then I ended up matching into matching in residency, where you go on a lot of dates for a month with various kind of programs. And I matched here in Phoenix at Abrazo Family Medicine Residency Program, and that was probably the best thing that ever happened to me because it's an unopposed program where you're the only residents in the hospital. You have a lot of autonomy. You have a lot of basically be able to pursue some of the things you really like. So that was great. So matched into there after 4 years of medical school. And it was a wonderful experience, right? So you get to do a lot. I did integrative medicine in residency. I did a faculty development fellowship. I became their chief resident, kind of building a lot of things. By the time I was done with my intern year, I had decided I was going to do a sports medicine fellowship because we have so much exposure. I was a team doctor, did a lot of volunteer work. I was a sideline ringside doc for boxing. And, sometimes you get a little bit bored too, and you're kind of debating about what am I going to do with the rest of my time in residency, because I had that pretty kind of wrapped up at that point too. And one thing that was always on my mind was pain. Going backwards just a little bit towards the end of medical school, this was after I matched into family medicine. My grandfather got diagnosed with pancreatic cancer. He was about 80 years old, never sick like a day in his life. I mean, he was convincing everyone that he was going to be like 110. Like that's what he was like. So just kind of completely out of the blue, got very, very sick. And he passed away within like 9 months. And so, I always kind of say sometimes it feels like people die twice. The guy die when they get sick because their entire life changes and personality changes. And then he passed away, and I didn't feel like I had a lot that I could do to help him. And so when you don't feel like you have a lot you can do to help someone, you want to learn more about it. He was in a lot of pain and discomfort and had a really poor quality of life towards the end. And so my last couple of rotations in medical school, I actually did pain management. And then I was blessed to rotate with Lisa Sears here in Phoenix, Arizona, who's a really big kind of palliative kind of pain doctor, she passed away when I was in residency. And then I did a few other kind of rotations. So pain was always something on my mind, and that's when I learned that was something you could do through family medicine. Very, very few people go through family medicine to do pain. It's about 1 in like 10,000. So very few, very blessed that I started looking at doing pain through family medicine. And so I started building up a really big resume for that moving forward. I published about 30 articles when I was in my third year of residency, and I was very blessed to write a few articles with some program directors for pain medicine fellowships. And so they got to know me. I remember my program director, who I ended up going to fellowship with, called me and asked me if I would apply to his program even before I ever applied to it. And so I thought that would probably be a good idea to want to interview at that program. Ultimately, I ended up doing my sports medicine fellowship in Long Beach. And that was tough because it was during COVID, but great hands-on orthopedic exposure. And then I ended up doing my pain medicine fellowship at Allegheny General Hospital in Pittsburgh. So that's the Highmark, West Penn, and kind of all of these different names because they're all these kind of conglomerates. And was there for a year, was able to have 3 other fellows with me, which is a great experience. And then something kind of cool happened by the time I was getting through fellowship. One of my peers and kind of co-residents started a business called HealthyU Clinics, which started in family medicine, but then was branching out into a multi-specialty group. And he asked me if I would be their pain medicine director because they were kind of going to start kind of building some other divisions. And I kind of bridged the divide as much as possible between primary care and specialty, even though I'm 100% specialist. And by the time I kind of got back to Phoenix, I wanted to kind of create this model for pain. And when I got home, I ended up getting board certified in obesity medicine as well, because we're really trying to kind of create a broad holistic approach. But pain is the primary focus. So that is the roundabout answer.
Perfect. What is your favorite part about pain?
Pain is puzzle solving. That's actually my favorite part about the whole thing.
Okay.
I think I mentioned TV shows already and things like that before, but I tell this story because it both shows my naivety, but also at the same time how much I really was influenced by things. I really liked watching like House growing up, right? So this this really smart Sherlock Holmes level guy trying to figure out problems with something, and he had a made up department which was called diagnostics, right? So it's like all the people who've got really hard problems and you're trying to figure out what's wrong with them. And then I got to medical school and I realized that wasn't a thing. And so that was really hard for me. So, and then, you get out into the world and you're like saying, okay, like what kind of cases do you take on? And so by the time I was in residency, it became really apparent to me that I like difficult cases and I liked things that people couldn't figure out, right? So that's been something that's always driven me towards pain, because pain, you kind of get a blank slate. You get a lot of times the patients that either people can't figure out what's wrong with them, or they have failed some kind of traditional things in terms of saying, okay, like it may be really kind of step one would be doing kind of physical therapy, maybe some just general kind of medical management, and maybe they even go to surgery at times too. And then when that doesn't work, you're kind of constantly asking yourself what else could be kind of going on with that patient. So that's been always my kind of favorite part about pain, and building that up and kind of really kind of trying to be the person who takes the time to understand what's wrong with the patient is very rewarding.
What do you see the most often in pain?
You see the most common things are always going to be the things that you see most often. Okay, so you'll always see things like back pain. When you talk to someone who does pain management, chronic back pain is the number one cause of chronic pain. And so when you're a pain doctor, for everyone kind of listening, chronic pain is the name of the game when it comes to that. Otherwise, they probably wouldn't be coming in to see me at that point. And the most common is kind of chronic low back pain. And then at that point, migraines and headaches are probably the second most common. And so you're kind of branching out. So we see a lot of head and neck, but I'm also a sports medicine doc, so I see shoulders, knees, hips, and everything in between as well.
And then as far as advanced procedures to tackle that pain, do you guys do anything that is unique to your practice where maybe patients might not know about, that you can address their pain in different ways?
Yeah, I mean, that's a great question, Scott.
Yeah.
I mean, we're fully interventional. So I do, outside of doing kind of things like blocks, epidurals, ablations, things that are pretty common. I also do spinal cord stimulators. I do peripheral nerve stimulators. I do intrathecal pumps, which not a lot of doctors do. We do minimally invasive spine procedures like minimally invasive lumbar decompressions, minimally invasive SI joint fusions. We do lots of things that are really trying to do. A lot of times you're trying to find a specific patient population this is ideal for, so it's not a blank slate saying one size fits all. But as I mentioned before, we see a lot of people where maybe we don't know kind of what's causing that pain, or maybe really the ideal way of us kind of tackling the pain is to block the pain signal. One of the common things with a lot of things like stim and stimulation is, for one reason or another, our nervous system starts functioning or becoming dysfunctional. And when that occurs, a pain signal can kind of be ongoing, where it doesn't matter if the surgery went perfect or the injury is healed. Now that pain signal is being amplified and going on for weeks and weeks, months and months, and then going on for years. And so we have some tools that really can do a wonderful job of blocking that pain signal.
No, and that's what I appreciate about your practice, is just the ability to use different methods to help the patient for wherever they lie. What differentiates HealthyU from other pain practices out there, would you say?
Our differentiating kind of factor has to be, where our background coming through like family medicine, I kind of see everything that walks in the door. It doesn't mean I do primary care. I'm not kind of managing diabetes and stuff, but the approach is very similar. Part of this is not everyone's a procedure, right? And I think that's also a really kind of important distinction. We'll see patients who have fibromyalgia, chronic pelvic pain, chronic abdominal pain, these kind of things too. And so when they're coming through our door, I'm there to kind of help them through that. I have a lot of people who've got autoimmune disorders that we're managing, co-managing kind of pain and stuff of that nature. So one thing that we wanted to do very early on was saying, okay, what are the other needs for our patients in our community that are different, that not everyone's addressing, right? So we incorporate weight management directly into our pain management in a lot of ways too, where, we have this conversation with patients. We're saying we're here to help you reach a healthy weight, healthy lifestyle, because it's going to help your back pain, for example. Simultaneously, chronic pain does quite a number on people's hormones. And so we will manage hormones for men and women, both in menopause, hypogonadism, these kind of things too, because we're ultimately still looking at it as this kind of collective. We have psychology in-house. So I have got 2 psychologists that we work very closely with, and I think that's really important for our patients to have. We do medical management as well. Not every practice does medical management. A lot of them are 100% procedural, where we want to have all the tools at our disposal to be able to help our patients. And so ultimately, we want to be able to approach everyone and not necessarily have an agenda when we're approaching them. We're saying, what are the best tools for you? Here are the options that we have, while simultaneously bringing it back to trying to improve someone's kind of quality of life and function, right? It's not just that you get to sit still and sit on your couch and watch TV all day and you don't have pain. We want to be able to have you do the things that you want to do and maintain your quality of life in a way that enriches you and everyone around you.
How can patients find you?
So my patients can find me at HealthyUClinics.com. You can make an appointment with us. We're on all major social media platforms. You can also find me on social media as well with my own kind of profiles. So happy to have anyone who reaches out.
Thanks, Dr. Dydyk. I appreciate you coming on the podcast. I just think that your practice is almost like a one-stop shop. You just have everything available. You're looking for the best for that patient that walks through the door. And so that's what I appreciate about it. So,
well, thank you, Scott. Thank you for having me. I really appreciate it.
Of course.